Hello, everyone. Thank you for joining us today. We'll be getting started in just 1 to 2 minutes. Hello, everyone. Thank you for joining the webinar today. We'll be getting started in just about 1 minute. Hello, everyone. In celebration of World Thrombosis Day earlier this week, Cardinal Health Medical Affairs is delighted to welcome you to this webinar on the latest evidence-based perspectives and blood clot prevention strategies in the new normal, the era of COVID-19 and beyond. My name is Bill Nadeau, and I'm the Global Director for Medical Affairs at Cardinal Health. I'm very pleased to moderate this important session and will now introduce our two speakers. Carolyn Crumley is board certified as an adult health clinical nurse specialist and a wound ostomy and continence nurse. Through a 40-year nursing career, she has worked in a variety of settings and currently practices as a wound ostomy and continence nurse at St. Luke's East Hospital in Lee's Summit, Missouri, and also serves as an adjunct assistant professor at the University of Missouri Sinclair School of Nursing. Denise Thomas is a board certified critical care clinical nurse specialist of 20+ years and a doctor of nursing practice. During the last 30 years, her clinical practice has focused on critical care, emergency, and trauma. Currently, she is the critical care clinical nurse specialist for St. Anthony's Hospital in the Denver area of Colorado. Both Carolyn and Denise are passionate about the prevention of VTE and have been working in their respective hospitals throughout the COVID-19 pandemic. Just a bit of housekeeping. During the presentations, please feel free to submit questions through the Q&A feature at the bottom of the screen. The chat feature will not be monitored. I will be compiling questions throughout, and we will have time at the end of the talk to conduct a question and answer session. In addition, we will be conducting a series of polls throughout, and we look forward to your active participation during the presentations. So without further delay, please help me virtually welcome Carolyn and Denise to deliver this presentation on the prevention of VTE, evidence-based perspectives in the new normal for blood clot prevention. Please go ahead, Carolyn.
All right, thanks, Bill. Thanks to Cardinal Health for giving me this opportunity to talk about something that I've been very passionate about for many years. So throughout this webinar that Denise and I will be presenting, we have the objectives listed there. The objectives are to discuss the public health impact of venous thromboembolism, or VTE, understand the connection between COVID-19 and VTE, identify new guidance from professional organizations and review established guidelines for use during elective procedures, describe challenges to developing a successful protocol for VTE prophylaxis, and finally, identifying nursing strategies for implementation and sustaining a protocol for VTE prevention in the new normal. Okay, my slides are not advancing for some reason. There we go. Okay, so venous thromboembolism. When we talk about VTE, we're talking about deep vein thrombosis, or DVT, and pulmonary embolism, or PE, as differentiated from arterial thrombosis that can cause like MIs and strokes. And so unfortunately, it's a very overlooked but significant public health concern. We know that probably half of the clots develop while patients are admitted to some sort of healthcare facility. And the sad truth is that as many as 70% of them may be preventable. And just unfortunately, even though we have a lot of very strong evidence to prevent them, a lot of times it's not implemented. So we'll be talking a little bit about what we can do to impact that. So this slide has some other kind of sobering statistics that you can read there. But I think the takeaway is that for many nurses, particularly working in acute care, we don't see sometimes the long-term consequences of this. You know, we're well aware that a patient with a pulmonary embolism is at risk for it being fatal. But even if they survive, they still remain at risk for developing a subsequent one. And even those that don't have an additional PE, well, many of them will develop chronic, debilitating pulmonary hypertension, which is going to affect them the rest of their life, that could easily have been prevented. Similarly, with patients with DVT, it may seem less serious and it may go on to resolve. Hopefully they won't have a subsequent one, or hopefully it won't travel to their lungs and create a pulmonary embolism. But even those patients that once it's resolved, over half of them will develop post-thrombotic syndrome. And we're all familiar with that. It's the patients that come in with the chronically edematous legs, with that brawny discoloration, can have the scaly skin, and actually even ulcerations that significantly impacts their quality of life. So there are many very simple measures that we can take to create a financial impact for our healthcare system as far as the many, many dollars that are spent on this every year. We're going to talk about a few of those. So this is kind of a busy slide. I know there's a lot on there to take in, but I like it because I think it helps to explain VTE risk factors, because there are many. And so Virchow's triad looks at the 3 different components that place patients at risk for developing a DVT primarily, and also a pulmonary embolism. And so the first is stasis. So that's anything that's going to interfere with the venous blood flow coming back to their heart. And so normally when we're up walking, our calf muscles help pump that blood back up to our heart. But when patients are immobilized and not moving around as much, then you have that stasis and the blood pools in their veins. The second is vessel wall damage. And that can be from a variety of different things, either from IVs, or perhaps a history of IV drug abuse, or any kind of injury. It could be trauma or surgery or any kind of fracture, anything that could injure those blood vessels that is going to make them more prone to blood clots developing along the endothelium. And then lastly, anything that changes their coagulation, anything that creates hypercoagulability. And that's such a broad category. The main factors that we think about are patients with cancer. We know that they're in a hypercoagulable state. Any type of infection or inflammation is also going to increase coagulation, but also many, many different medications, hormones, oral contraceptives, advanced age, obesity, smoking. Any of those factors can contribute to the patient being at higher risk for developing a DVT or a PE. And if you think about it, most of our patients that are in the hospital are going to have at least some of these risk factors. And then we've got a couple examples there of some treatment options, some prevention options, as far as lower extremity intermittent compression, pneumatic compression devices, TED stockings, and anticoagulation that we'll talk about here in a minute. So we already know that many of our patients are at risk for developing some form of VTE, and then enter COVID-19, which we know has kind of turned our world upside down and only made this problem much, much worse. So we all know about stay-at-home orders and our limited mobility, especially for some of our elderly, very high-risk patients, or particularly patients that have COVID. They're certainly not up moving around, so they're going to have those issues with that venous stasis. We're learning more and more about the impact that COVID-19 has on many other components beyond our lungs. They're finding that patients with COVID-19 have some mild thrombocytopenia. They have increased D-dimer levels, increased pro-inflammatory cytokines. There may actually even be some liver dysfunction with some increased antiphospholipid antibodies that are going to, again, speak to that coagulopathy or that increased risk of developing blood clots. Many of the patients are going to end up on some form of positive pressure ventilation. And as that increased pressure in the lungs impairs with the venous return in the lungs, then that's going to increase that stasis and also place them at more risk. And in fact, they're finding, even though we think that, most pulmonary embolism probably start as a DVT and travel to the lungs, that many of these patients may actually even be forming them in their lungs. And the evidence suggests that many of, especially the very sick patients, end up with disseminated intravascular coagulation and problems with that. So, you know, the evidence has been coming out fast and furious from all these various different centers, and there's been a lot of conflicting evidence as far as what the rates are with our COVID patients. And so initially, the American College of Chest Physicians, when they had reviewed all of the evidence, suggested that the cumulative incidence may be anywhere between 20 and 59%, so quite variable. But there was actually just a publication last week, hot off the presses, too hot to make it to the slides, from the International Society of Thrombosis and Hemostasis. And they actually performed a meta-analysis of 66 different studies that have been published in regard to the prevalence of VTE in COVID patients. And they found for those patients in the ICU, the prevalence of DVT was 23%, and for PE, 14%, so very significant. For non-ICU patients, certainly less risk, but still 14% of those patients had a DVT and 4% had a PE. So Denise is going to talk a little bit more about some strategies that we can do to improve our VTE prevention, but mainly the barriers fall into one of three categories. Either first, that the patient really just isn't identified at being at risk, and as we know, really pretty much all of our patients in the hospital are going to be at some sort of risk. Prescription variability as far as recommendations. There was already an issue with that before COVID. We're going to talk a little bit about some of the recommendations specific to COVID, but still some unanswered questions and some differences in opinion as far as the doses and who needs the pharmacologic prophylaxis. And then one of our biggest issues is therapy noncompliance. So that could be either in relation to the pharmacologic, and not that it's intentional, but just missed doses, or with the lower extremity compression devices, just patients and nurses not understanding the importance of it. So then what do we do about our COVID patients as far as assessing their VTE risk? Well, we can use any of the standardized risk assessments that are already out there, the Caprini, the Padua, or the Improve. But we also need to think about, again, going back to that slide with all those additional risk factors, that these patients are going to have even more risk factors than our average patients. They're going to be confined to their rooms. I don't know about you, but we're not letting COVID patients up and around, so they're pretty much stuck in their rooms. Not only them, but the other patients too are not wanting to get out in the halls because of the patients with COVID. They have the infectious disease that we talked about, the inflammation, the infection that increases their risk of hypercoagulability. And so most of the recommendations really recommend that all of the patients be considered at risk for developing a VTE. So what do we do as far as prophylaxis? Oh, sorry, we have a polling question. So we'd like to have your feedback as far as what you do within your facility. Now this is for all patients, not just patients with COVID, but we'd like you to answer this question. At your facility, what is your approach to venous thromboembolism risk assessment to determine prevention measures? So again, for all your patients. Do you use no risk assessment? Do you use an individualized risk assessment using a standardized tool, like one of the ones that we talked about, Caprini or the Padua or Improve or one of the other standardized tools? Do you use an individualized risk assessment using facility developed tools? So did your facility come up with their own tool? Or do you just consider all patients at risk and have an opt-out for the small number of patients with no risk factors, which kind of came into favor a few years ago? Or do you just simply not know what your facility does? So we'll be curious to see what's going on in your facilities. We need the little Jeopardy music. I'm not going to sing for you. Okay, so we've got some answers there. Okay, well, very good. It looks like the majority use an individualized risk assessment using a standardized tool, so 39%. So very good, very good. That's really what the recommendation is. Again, a while ago there was the trend had been to maybe just sort of consider everybody at risk, but then we realize that you need to weigh some of the bleeding risk in that for those patients that maybe don't need prophylaxis. And it looks like a fair amount of people, 14%, really aren't sure what their facility does. So hopefully we'll give you some more ideas on how you can improve that in your facility. Okay. Okay, so then as far as the COVID-19 patients and recommendations, there again are literally hundreds and hundreds of articles out there. And so what I chose to do is look at the 5 different publications that have been posted recently by these various very well-recognized organizations. And of course, it's beyond the scope of this webinar. We were originally looking at trying to identify all those different recommendations, but they each include a lot as far as both prevention and treatment specific to COVID-19 patients. So I would encourage you to review those. What they did as far as just kind of an overview of what they recommend, the American College of Chest Physicians is pretty much recognized as the leader in this area. They're the ones that post the regular VTE guidelines every few years, update those. And what most of the guidelines did was break it down into acute care patients and critically ill patients. And so obviously identifying that those critically ill patients with COVID are going to be at greater risk, and so favoring more pharmacologic prophylaxis for those. But now in our age of COVID, we have so many other things to consider as far as staph exposure, any possible heparin-induced thrombocytopenia. And the reality is that with a lot of the treatments that we're using for COVID that seem to be coming out all the time, we don't really know what kind of interactions there may be with the direct oral anticoagulants. And so that's why many of the guidelines favor using low molecular weight heparin or fondaparinol over unfractionated heparin, and looking at some of those parenteral options as opposed to the ones that could interfere. The other thing that some of the guidelines recommend, and they're still somewhat debatable, is whether these patients with COVID, instead of needing the standard prevention prophylaxis, whether they need to have full treatment dose, or some of the guidelines are recommending what they're calling an intermediate dose. So it's kind of between the standard prevention dose and the normal treatment dose. But again, we realize that these patients are at greater risk, and so we probably need to step things up a little bit. So then for those patients that are already on anticoagulants, and what does that mean in our era of COVID? Well, I guess the CDC had recently posted a document at the start of COVID saying that patients that are on antithrombotic agents may have an increased risk of contracting COVID-19. So there was some fear that maybe patients would stop taking them to avoid the COVID-19. And so we know that that could have some disastrous effects. And even for those patients that are continuing to take their vitamin K antagonists, their warfarin, who need the outpatient monitoring, you know, they may be reluctant to go in for testing for a while. They may not have even had testing available. I think most things have opened back up now, but just needing to take into consideration some of the challenges that they're facing with that and what they may need to do to overcome some of those challenges. So one thing that all of the guidelines, the COVID-19 VTE guidelines, recommend is mechanical prophylaxis. And this may be either in conjunction with pharmacologic, or it could be for those patients who are at risk for bleeding, that it may be the only option available for them, because again, we want to weigh that risk of bleeding versus preventing VTE. So we have a lot of different types of lower extremity compression devices that are out there, and I think a lot of times as nurses we tend to refer to them all as SCDs, or sequential compression devices, but really there's a lot of variability out there. They're not really all sequential, they're not all circumferential, and so we may need to think about some of the benefits of using a true graduated sustained compression, graduated sequential compression versus just that on and off again compression. And so there have been evidence to show that using these type of lower extremity devices can increase the total blood volume moved, because again, what we're trying to do is keep that blood from pooling in the legs, trying to get it back up to the heart, mimicking that ambulation. Sustained blood flow, so keeping that blood going in the right direction and avoiding that backflow. And then also some differences in the venous refill times. And so we want to try to maximize the benefit of these lower extremity compression devices and making sure we're using one with evidence. And again, just some additional evidence to support the improved efficacy of circumferential sequential gradient compression devices as far as improving the venous return. So we have one more polling question for you. We'd like your feedback on this because we know there's a lot of variability in how facilities use the various, whichever type of lower extremity compression device that you have. You may not even be familiar with exactly what type you have and what the specifications are, but how many of your patients in your facility use lower extremity compression devices? Would you say less than 10%, 10 to 25%, 25 to 50%, 50 to 75, 75 to 99%, or are you one of those overachiever facilities that 100% of your patients use the lower extremity compression devices? We would love to see that. That is our goal here. So we'll give people just a minute to respond, and then I'll be curious again to see what the answers are, what the poll finds. Okay, well, okay, that's pretty good. 50 to 75%, we'll take that. You know, we still have a few of those facilities, less than 10% or, you know, under 25%. We have 7% of you are overachievers, and 100% of your patients at any given time have lower extremity compression devices on. So kudos to you. Kudos to you. We'd like to see those numbers increase significantly. Okay. So I thank you for your attention, and I'd now like to turn it over to Denise, who's going to talk about some strategies for improving VTE prevention protocols in the hospitalized patients. Okay, Denise.
Thank you, Carolyn, and good morning or afternoon, wherever you are living. The next section, we're going to be talking about how to actualize developing a VTE prevention protocol. As Carolyn mentioned earlier, it's well documented that patients positive for COVID-19 develop a hypercoagulable state, increasing the risk for VTE. It's also well documented that hospitalized patients are at an increased risk. So implementing a VTE prevention protocol for all of your hospital patients will improve your patient outcomes. Next slide, thank you. Hospital-acquired VTE can be prevented using well-designed processes and protocols. Implementing changes in practice to reduce VTEs requires multidisciplinary advocacy. LIPs, pharmacy, nursing leaders, champions from all the units involved. You need to develop a process for auditing with feedback, develop education for nurses, LIPs, pharmacists, and always include patients. And you need to plan for identification and mitigation of variances to the protocol. The process for VTE prevention begins when the patient is admitted to the hospital. An LIP performs a VTE risk assessment. The computer links a patient's VTE risk to an appropriate VTE level, and the LIP orders level appropriate VTE prophylaxis. And then you finish that up with reevaluations. You want to begin the protocol by selecting an appropriate scoring tool. The biggest thing is team consistent and agreement to use it. That's going to improve your compliance. Given the varying VTE prevention recommendations from professional societies, it is extremely difficult to select one tool that meets all the needs of all the populations. And failure to form consensus on best practices may be the biggest barrier to your protocol success. The quantitative models are valid, but they're very time consuming. The qualitative models are basic, but they're easy and quick to use. The empiric models are derived from observational studies, and therefore they're more facility specific. So you need to select a tool that facilitates and supports use in your hospital's workflow. Electronic health records seems the most efficient. However, a paper reference actually may support a different tool use. The scoring tool must be appropriate for the population you're treating, and different specialties may weigh risk factors differently. The surgical patient weighs differently than an active cancer patient or a trauma patient. In 2016, Sultan and Grange published a risk assessment model specifically for obstetric and post-cesarean section patients. So when translating these professional society recommendations into best practices and the order sets, consider implementing in phases. You might want to start with a limited scope, maybe just the orthopedic patients, or perhaps just in your ICUs. And simple scoring tools may be easier to implement. If they only have 2 to 4 levels, makes them easy to use, but also easy to embed in the workflow. Question is where does COVID lie in the scoring? Well, that's still under discussion. There was a 2020 China study by May and colleagues who showed that the risk assessment score associated with COVID-19 pneumonia demonstrated a hypercoagulative state. However, the incidence of the VTE was not significantly higher than the community-associated pneumonia. So it seems a wee bit confusing. So until more evidence is available, risk scoring for COVID-positive patients may be determined by your individual facility. Using the selected risk assessment tool, you want to score each patient's VTE risk at admission, on transfer. And don't forget if a patient has a change of status, because patients who worsen may require an adjustment of their thromboprophylaxis. You want a reassessment of the risk and the appropriateness of the therapy. You want to consider at that time, if you have someone who's post-op, you might want to reassess them in 24 hours because they will have a change in status, or 24 hours after a C-section. Your neurosurgery patients should be reassessed in about 5 days after surgery, because as a patient recovers from a procedure, anticoagulant therapy may no longer be contraindicated and is now actually beneficial. Some facilities also add an independent reassessment using a pharmacist or nursing. The level of the VTE risk guides your therapy. So if you have a low risk, you may require only early ambulation, no other prophylaxis. Moderate risk, which is most of the general and medical and surgical patients, they may add an anticoagulant to ambulation or pneumatic compression device. A high-risk patient, we're talking your multiple major trauma patients, continue mechanical prophylaxis and the anticoagulant that you may see in your moderate risk, but you may notice that the anticoagulant dosing could be increased. Bleeding risk should always be part of the risk level determination because it impacts the use of the anticoagulant and its dosing. So bleeding risk can change during a hospitalization, especially before or after a surgery. So reassessment ensures that you're giving the appropriate therapy. You want to consider leeway times for bleeding risk when they're having a specific procedure. For example, hold anticoagulants for 12 hours prior to putting in an epidural catheter or prior to its removal. You want to wait 36 hours for a TBI or intracranial bleeding. For post-transplant or multiple major trauma, they clear bleeding around 48 hours. Also want to consider contraindications for your pharmacological prophylaxis. Include that in your screening. The result from a valid VTE risk tool, identifying the bleeding risk and the contraindications, if you put all those grouped together into their levels, so you have a low, you'll have a medium, and you'll have a high. Then you develop standard order sets that are linked to that specific risk level. I cannot stress enough the importance of having a pharmacist consult with the development of these orders. It's important to have a standardized menu of choices linked to the level of the risk. A high risk, for example, as you can see on the slide, a high risk would have one medication, but perhaps it will have 2 different dosing options. Having risk link order sets decreases the time and confusion seeking appropriate choice while supporting consistent evidence-based care. When developing risk level order sets, consider the need for order sets that are specific populations such as post C-sections orthopedic hip, knee surgery, and use weight-based dosing if you're using heparin. Consider the type of medication. Are you using vitamin K antagonists? Are you using DOACs? Are you using heparin? The duration, the appropriate VTE prophylaxis with discharge. You want to identify clinical endpoints. You also want to have order sets that allow for alternative dosing for patient-specific selection. So as Carolyn mentioned earlier, what if the patient is already on an anticoagulant? Now comes the COVID question. Due to the lack of quantity and quality of research, practices vary in prescribing VTE prophylaxis, especially anticoagulant therapy. Some practitioners maintain the same dosing for COVID patients as non-COVID patients, as frequently reported in the UK. The literature from China, however, suggests doubling the anticoagulant dosing in COVID patients. And some, like my facility, we perform tweener doses, which is more than normal, but it's less than double. There are several studies that were just published actually this month that support the use of anticoagulants in COVID-positive patients, but they're really basing the dosing heavily on the patient's risk factors for bleeding, particularly the risk for intracranial hemorrhage. You want to enlist pharmacists to provide real-time decision support for optimal agent, the dose selection, tailoring to the patient's comorbidities and their preferences, and also discussing contraindications. There was a study at Johns Hopkins in 2013 that reported nearly 60% of missed doses were due to the refusal of patients or their family members. This is nursing. Nursing addressed challenges like patient refusal. They also ensure the adherence to medication administration and avoid of missed dose. Compression devices may be used on most patients. They require an LIP order and therefore they should be included in the order set. So additionally, you need to have access to the equipment. It should be 24/7 because you need prompt implementation with admission. You might want to consider as part of the room setup in your ICUs. You also need to know the type or the location of the device that they're going to be used for that particular patient. You're going to use bilateral lower extremities, or you're going to use foot-only devices. Now mobility, oh, this is it. Mobility is a nursing intervention. We own that, we control it. And nurse-led mobility protocols have been shown to be effective in reducing immobility-related complications, such as VTE. Most electronic healthcare records easily support both the screening for the patient's stability and the levels of the activity performances. Ambulating a COVID-positive patient requires the assistant to use the close techniques that they use for infectious patients. So they're going to need full PPE. Patient is going to need a mask. If you can keep your face turned away from the patient as much as possible, that's the best suggestion we can give you. I'm not sure how everyone does their COVID patients, but we have a unit that's a COVID unit. We made the entire unit negative pressure, so our patients could walk in the halls. But in our ICUs, only the rooms were negative, so they needed to ambulate in the room. Or if the room is really small, they can walk in place. You want to select a mobility program that is appropriate for your institution and the population that comes to your place. Is it easy to document? You want to ensure compliance. Can it be incorporated into the electronic healthcare record? And can measure of progression of the mobility activities be visualized? A few mobility protocols have already been established, such as the Braden 4-point degree of ambulation scale. And they also have population-specific protocols, like the American Association of Critical Care Nurses Early Progressive Mobility Protocol for critical care patients. You have the Adult Bedside Mobility Assessment Tool for the adult patient in the acute care areas. And you have the pediatric BMAT for the pediatric patient in the acute care areas. Upper extremity DVTs can account for up to 40% of all hospital-acquired VTEs. The central venous catheter or peripherally inserted central catheters are the most frequent cause of upper extremity DVTs. Using criteria specific for CVC and PICC lines, you need to adapt protocols for when it's appropriate to insert and when is it appropriate to remove. Additionally, performing daily assessment for necessity promotes early line removal. To maintain a target anticoagulation, include interventions requiring an LAP order within the VTE prevention order set. You want to define strategies to identify under and over prophylaxis within 24 hours of admission, and if possible, throughout the hospitalization. You want to do a daily review with multidisciplinary or LIP rounds. You want to include the electronic healthcare record report of outliers, and that can be a facility-specific report. You can add an automatic addition of outliers to the pharmacy work list. So usually that requires a hospital system approval, but can be done. You can add BPAs when lab results are outside designated parameters. Determining how to measure anticoagulant levels is still lacking consensus. The rapid influx of various COVID studies makes selecting one lab diagnostic to guide practice still debatable. Some tests currently used are the anti-factor 10A, D-dimers, and INRs. There's recent discussion, I just saw some studies that they were preparing to do regarding the use of the more specific coagulation products of the viscoelastic testing like ROTEM or TAG. You want to include in the order set protocols for dose adjusting. So when anticoagulant is outside the target, allow the nurse to hold heparin or administer vitamin K based on designated lab values. You want to allow pharmacists to manage unfractionated heparin and warfarin dosage. Pharmacy-driven warfarin management has proven to be the most successful method for preventing high INRs. Thank you. Educating patients and families allow for better understanding, participation, and adherence to recommended prevention activities. Nahar's study of 2018, he demonstrated that providing just a simple education pamphlet increased patient knowledge and compliance with mechanical prophylaxis. The patient or the family actually may be the first to notice complications of anticoagulation or the side effects of mechanical prophylaxis or the symptoms of a VTE. Several studies have shown that nursing's perception of subject knowledge and patient need does not always reflect the actual situation. So providing nursing education regarding VTE risk and the impact of prophylaxis improves patient outcomes. Lau reported in 2017 in his study showed that overall nurse education reduced the frequency of VTE prophylaxis non-administration. Okay, so we've got this all going forward. Now all we need to do is focus on how we're going to sustain this. How are we going to ensure that the practice changes that we made are going to be cemented in daily use? You want to do consistent daily review, multidisciplinary or LIP rounds, review mobility level and progression. You want to review central line necessity. You want pharmacy to review the anticoagulants. You want to use a script or a reference sheet just to keep you on track. The electronic healthcare record involvement is directly proportional to consistency. So risk link order sets could force completion of a risk assessment. Order options only for the specific level that the patient has been assigned to. The EHR can have alerts like when the lab is outside the target, when it's time to reassess for risk. Mathers did a study in 2017 that an electronic alert system was associated with a significant increase in rates of pharmacological VTE prophylaxis. The record can also print out reports for you or develop reports for you. It can help you calculate your weight-based heparin dosing. And the audits, remember, you are what you measure. Electronic reports are great. I personally like the stoplight reports. They're very easy to identify compliance. You can always do them manually. But the big thing about the audits is who's responsible for addressing the variances on your unit. And then you need to take it to a report like a huddle, like a manager huddle, where managers from all over the hospital get together once a day and they share, and they have to share their results. And let me tell you, peer pressure can be a strong motivator. Next slide, thank you. Leadership, nursing, and physician commitment power sustainment of evidence-based initiatives. Consensus among the healthcare team regarding importance of addressing the VTE prophylaxis is critical to the program's success. the most powerful strategy positively impacting program results can be the executive leadership by promoting initiative accountability. Take what you already have, build on a current successful initiative. If your CODI rates are very low and everybody is solid and they're doing exactly what they're supposed to do, build on what you learned from that, or CLAPSI, or CDIF. VTE is a common and costly cause of healthcare acquired morbidity and mortality. The literature is clear that many, if not most, cases of hospital-acquired VTE can be prevented using well-designed processes and protocols that link risk assessment to prophylaxis orders. Use your evidence-based guidelines. Include smart technology as much as possible. And share your results regularly to everyone, to anyone who will listen in the elevator, and celebrate your successes. And that's it. Thank you very much. I think we have a few links and resources.
Carolyn, Denise, thank you. Congratulations to both of you for excellent presentations. And on behalf of everyone, thank you for your outstanding efforts caring for patients during the pandemic. As Denise mentioned, the references and resources will be made available to you because this webinar is being recorded and will be made available within a few days, accessible on the link, via the link on the bottom left of your screen, cardinalhealth.com/WTD 2020, standing for World Thrombosis Day 2020. We will now move over to the question and answer portion of the webinar. As a reminder, please continue to submit questions through the Q&A feature at the bottom of your screen. The chat feature will not be monitored for questions. As the team starts to thumb through those questions, I'd actually like to ask the first one, if I may. Denise, this one will be for you. I found your comments really compelling about how you can leverage other protocols that exist today, like the CODI prevention protocol, that you can then use when developing VTE prevention plans. Maybe you could elaborate a little bit on that for me.
Well, I think that you have to have a framework for any project or any protocol that you put out. And I think if you can build on something that's already been established, that framework is going to be solid. If you pick one that you're successful on, it's going to aid in the development of new ones, but it's already known. So people jump on board quicker, things go a little faster. You've already worked out the bugs. Maybe just few minimal adjustments are needed to establish format changes, electronic record supports, like reports and documentation. And actually, if you had success on another protocol, then that helps motivate people because they're going to think, well, if that one was successful, we're building on the same framework, this one's going to be successful too.
Great, thanks for sharing that additional perspective there. Carolyn, I think maybe this one would be for you. The question is, what strategies, programs, or actions have you found successful when it comes to educating staff?
Okay, well, yeah, that's always a challenge because there are so many competing demands and so many things trying to educate the staff on. And, you know, the normal avenues for providing staff education, you certainly want to utilize those if you have clinical educators or if you have opportunities on like skills days or education days. But I think a couple of the things that have helped in the past to gather attention for us have been, first of all, either kind of putting a face with the condition because, you know, we look at all those numbers, we know that it's daunting, but a lot of times just those statistics themselves aren't enough to motivate people. Even if you share it in comparison to more people die from VTE than from AIDS, cancer, and motor vehicle accidents combined. I mean, there's all different statistics comparing to other conditions. But putting a face with it, I know here in Kansas City several years ago, we had one of our Chiefs players who happen to be the world champion Super Bowl champ Chiefs. I'm wearing red both for VTE, but also for the Chiefs. One of our Chiefs players, Derek Thomas, was injured in an accident, spinal cord injury, but was recovering and developed a very sudden and fatal PE. So I think normally when I do these presentations, I have pictures of either local people or celebrities who have either died or been affected by a VTE, and that kind of puts a face with it. Or if you have a family member who has lost someone from a PE that could have been prevented, and have them talk about, you know, what it has meant for them and having that loss that was so easily preventable, I think that has an impact. The other thing is making it fun. We also had, every year we would have the clot busters visit. And so we would get the white bunny suits from OR, make a little proton pack from our lower extremity compression device with the lower extremity device wrapped around as our wand. And we would have the Stay Puft Marshmallow Man there to hand out Rice Krispie treats. And of course had information about VTE. So just anything you can do to make it fun or get their attention, because again, there are so many other competing demands throughout the hospital.
Great stories to add to the answer. Thanks for that, Carolyn. This question came in from Tanya. I think this one, maybe we'll stick with Carolyn to respond first. For those using a standard risk assessment for VTE, who does the assessment? Is it nursing or is it the prescribing providers?
Denise and I don't know if you can see us both, but we're both laughing. Yes, that is a challenge. And in my practice, we've kind of gone back and forth. We felt like it was nursing because they're going to be doing the assessment. But then again, a lot of particularly the pharmacologic prophylaxis is dependent on a physician order. So I guess in an ideal world, it would be teamwork and you would be working together. But I think you just have to look at your facility. And again, kind of looking back to some of those other initiatives and what's been successful, which is more successful, and then also including pharmacy too.
Yeah, I would echo what Carolyn said. And actually there was a hospital in New England who had nurses do it. It was completely nursing responsibility. But as you mentioned, there are some contraindications in the patient's past medical history or in the plan of future projects or procedures that is going to happen that maybe the nurse wasn't completely aware of. So I agree, it's a team. I meant the nurse does the great assessment at the bedside, the physician has some great history, and the pharmacist can pull it all together by taking all that information and then monitoring it. So I agree, it is a team effort. I think at least at our facility, the physicians start it, but then we reassess, and then that's where the team gets involved.
Great, thanks for sharing your perspectives. This next question came in from John. He asks, how long does IPC or SCD need to be applied in order to be effective according to the literature? Now, I'm sure this is heavily debatable. I remember seeing 18 hours per day minimum per chest guidelines. But do you, Denise, maybe we'll start with you. Do you have any suggestions there?
Oh, that's a great question. Because let's be completely crystal clear here. Only our ICU patients are maintained the quantity of hours that are needed. I have to tell you that in our acute care areas, we try to do 12 to 16 just because we're trying to get them ambulated. So if they are not ambulating at least 3 times a day, not counting going to the bathroom, and they're ambulating distances, then we probably won't apply the IPCs just because it would be so sporadic, you know, a couple hours here, then we get them up and that doesn't work. And so for them to, if they're not ambulating for the length of time we want and the frequency that we want, then we're going to apply them. But we try to do like 12 to 16.
Great. Well, perhaps Kevin's question would just ask you to elaborate on this a bit more. Kevin asks, are there best practice parameters around frequency and distance of ambulation to prevent VTE?
Kevin, I'm not sure I like you. This is a huge discussion debate. We have a mobility committee for our hospital, and we get together and we have discussions that are, oh, did you read this? And oh, did you read that? And I'm going to be just honest with you. We have not come up with consistency for all the units, and they're very individualized. We have a cancer unit. We have a trauma unit in the acute care areas. And so they have kind of different standards and different requirements. We have initiated, or we are trialing a new program where we put colored feet that stick on the wall so we can measure how far people are walking. So if they don't meet a certain criteria and it's for a certain period of time, then we can always add the IPC.
Yeah, and I think just to add to that, I think the reality is, I mean, yes, we don't have any solid evidence about how often or how far, but I think common sense would tell you that the reality is that very few of our patients are walking enough to overcome the immobility the rest of the day. I mean, any mobility is good and is great for a variety of reasons, not just VTE, but they're probably all still going to need prophylaxis.
Great, thanks for your perspectives. There actually are a number of questions coming in on ambulation here, and I think hopefully we've covered a lot of them. I just want to acknowledge Danielle, of course, asked, I work in a unit where patients are usually only there for a couple of days. If a patient is ambulatory, are SCDs still encouraged? And I'll ask the next one as well, because it's kind of the same theme. The suggestion that ambulation is an acceptable means of VTE prevention. Should we still be applying our IPC, our SCDs, even when the patient is ambulating? Anything else to add there? Denise, I'll ask to go to you first.
I think what we kind of settled at from reading the confusing literature is that if the patient is not walking, the SCDs are on. So if we get them up and sit them at the bedside, so sit them in a chair so they can eat their meals, they have the SCDs on. And then they get back. I mean, obviously we disconnect them, and it is a fall risk, which was one of the reasons we had huge discussions about. But I think that we've kind of landed on, if they're not walking around, even if they're sitting in a chair watching TV, they have SCDs on.
Yeah, and I think it's just easier from a implementation standpoint too, if you just sort of get all the staff clued in, because then the more exceptions there are, the more likelihood that they're not going to follow through. And so if you just sort of make it the exception that everybody that's not up walking in the hall at that particular moment needs to have them on, you know, unless there's some contraindication, which there are very few.
Right. This next question came in from Jennifer. What are your suggestions for polytrauma patients who may have bilateral lower extremity fractures with vascular involvement that make it difficult for SCD as an anticoagulant therapy? Denise, your trauma expert here. I'll hand it over to you
Oh my
first.
gosh. That is like a nurse's nightmare on let's do prophylaxis. We know we have to do it. What are we going to select? We have actually put the foot only devices on, if we can, on certain patients. We have done one leg, not both. We put them in as much as we possibly can. If we cannot, I can guarantee you that we are adjusting with anticoagulants. But as soon as, like, if they go in for surgery a few days later when the swelling has gone down or they've cleaned out the open wounds, then as soon as we can, we'll put them on. So as soon as they've closed the wounds and the bones are secure, we put them on.
Great, thanks for that question. And thanks for that response, Denise. We have time for maybe one or two more questions. Carolyn, this one's for you. If a facility's VTE rates are already low, how do we continue to motivate the team to never lose focus on VTE prevention and sustain those low rates?
Well, that's a good question, because I think sometimes what happens with whether it's VTE or any other project that you're working on, if you get to a point where you're doing well, first of all, I would make sure too that it's accurate data and that you're continuing to look at it. But sometimes you can get sort of complacent, like, well, okay, we've fixed that, we've taken care of that, and we can move on to the next thing. But as we've all probably seen, is as soon as you stop monitoring it, then you're going to see those rates go back up. So I think you certainly want to celebrate those successes. Take what you can from that to apply it maybe to other initiatives like Denise talked about, but you can't lose sight of the fact that those rates could continue to climb if somebody's not continuing to monitor it. So you want to continue to monitor both your rates and your the program overall.
And we do similar stuff, sorry, at our facility, in that we celebrate successes. We count how many days, how many months, how many years go by without an event. We try to remove any barriers that we identify, because anytime there's an event, we do a deep dive to figure out what the cause was so that we can prevent it from happening in the future. But I think sharing that information, exactly what Carolyn had said, is huge, because it's really heartbreaking when you hear that your patient had to stay extra couple of days, or that they couldn't go home, they had to go to a sniff because of something you neglected to do.
Great. And I think this last question from Seth might be a good one to end on. Denise, maybe you could start the response. How can we go about fostering VTE champions in our facilities?
Okay, as a CNS, I love to share data. So I like to show how each unit is performing. My units, they are a little competitive. So if we can show them how well they're doing, where are we falling out, and what the number of events are, has it, when it decreased, did we have a champion that helped with that? When we didn't have a champion, what did we see? As I said before, we evaluate each one, we have a deep dive. And we look at all the events to find out, can we learn from one mistake or from one error? And depending on what that mistake or error was, the champion sometimes can pop up out of the woodwork going, oh, that's one of my favorite things to address. I'm very passionate about this. And we just, reel them in and say, here you go, let's do this, and let's spread it throughout the whole hospital.
Yeah, I would just say, yeah, I think unit-based champions are really the way to go with whatever initiative it is, because if you're, a clinical nurse specialist, whatever your role is, you can only do so much when it's just you and the whole hospital. So I think having somebody on each unit who is the champion for that particular project, and if you can ideally find somebody that's really passionate about it. Again, some friendly competition, sharing rates, that seems to always work. Everybody wants to be the best at everything. So when you are transparent and show how their unit is doing in comparison to other units, that's very motivating. And just providing education to them, and just having them be the person out there in the rooms, helping the other nurses and helping to reinforce how important it is for the patients, whether it's to wear their lower extremity compression devices, whether it's, making sure that we're not missing doses of their anticoagulant, that we're educating the patients appropriately, then I think that's really the only way that you can have an impact throughout a big system.
Fantastic. We have at least a dozen other questions that have come in, including questions from Mary Ellen, as well as from Nikki looking at post-acute. I apologize, we will not be able to get it to any more questions because we are nearly out of time here, but we will aim to respond to your questions individually. Please continue to reach out to us with additional questions if you have them. So in closing, there will be a brief survey, very brief survey made available to you when this webinar ends. We would greatly appreciate your feedback on how we can continue to provide you with the most relevant clinical education. So please be sure to share your feedback in this survey. Please also visit cardinalhealth.com/WTD2020 to learn more about VTE prevention efforts. Thank you again to Carolyn and Denise for outstanding presentations, and everyone else for joining. Have a wonderful day.